Sadly, we don't have the opportunity to do this in person, which is far and away my preferred method. But I'm glad to be able to take part in this. My name is Scott Smith. I'm a professor of social work at Oakland University. I'm also on staff at the medical school, Oakland University, William Beaumont, as well as on staff at Beaumont Royal Oak in their emergency department, where I do psychiatric intake. I've got 20 plus years doing crisis-based psychiatric social work, worked in a wide variety of settings. And while child welfare holds a dear place in my heart, I have intentionally avoided direct work in child welfare. And I've done so because A, I was a child who grew up with some contact with the system, and B, I have never been under any false illusions that it is without a doubt the hardest work within our field. And something I make abundantly clear to my students every year is that I'm going to do my best in class to present them with kind of the realities of what it's like to practice and have contact with the child welfare system, because I think too many of us end up trying it on in person and seeing if we like it. And my theory is if I can talk you out of child welfare by describing cases or things I've seen in the emergency department or in the field, doing other crisis work, then you're hopefully able to make a decision that doesn't involve experimenting on humans. When I was approached to do this presentation originally, the hope was that I would do something similar to what I had done before, earlier this fall, training on suicide assessment for clinicians. And that focused really on helping you to have confidence to make a call about what to do. Part of what we've seen as suicide rates have increased in recent years is that it's kind of exposed the lack of confidence that many clinicians have to actually make a decision. And instead, they end up deciding to let somebody else do it. So I can speak a little bit from what life is like in an emergency setting, emergency room setting, when we get an influx of these suicide cases. And unfortunately, what happens both in that setting and long term doesn't necessarily improve outcomes. And I'll get into more of that in a minute. But I wanted to contextualize it more working with you as individuals involved in the child welfare system, because essentially when we talk about the known risk factors for suicide, show me one of your clients that doesn't have all of them. Essentially, the reality is that it's so ubiquitous that everybody you work with is going to have multiple risk factors for suicide, and it should probably leave you feeling a little bit like dizzy. How are you supposed to know what does require attention? Do I refer everybody to some type of service? What do I really do? So I want to be able to speak to some of that as well. And more importantly, I want this to be your training. As a social worker who has to complete CUs as well, I know the tendency to just pop on something and listen to it and do other things. And I get that. But we will definitely have an enhanced experience if you're willing to chime in and participate. So often I'll ask questions, and you might notice that I'm quiet for a period of time. Probably a great indicator that I was, in fact, asking a question, and would love to have you chime in and share. I know Chantalea, who, by the way, is my favorite rock star in the universe. She's so capable and coordinates so many things, and so I really want to just extend a lot of gratitude to her for making this and all the other trainings that Wayne State hosts even happen. She's going to be manning the chat box as well, and will help chime in too to make sure that I can respond to your questions. So without any further ado, we'll kind of get into this, and we'll want to talk about the landscape we're really looking at in terms of suicide in the US. And when we go back to 1999, what we see is that overall suicide rates are rising. This doesn't come as a surprise to any of us. The number 24%, these are confirmed suicides. Some estimates place it a bit higher, especially since Suicides among older adults are often not classified as suicides because they lack some clarity, but at least 24% higher than it was in 1999. And this translates, sorry, there we go. This translates in 2019 to almost 48,000 suicides in the US, which actually was almost 10,000 more deaths from suicide than we saw from automobile accidents. And by the way, the most recent solid data we have is 2018. There's preliminary estimates of 2019. The 2020, 2021 numbers, wow. The first number I saw related to that window was over 100,000. We don't know much yet, so I'm going to refrain from touching on that. And we're just going to pretend that we live in a like pre and post COVID world, but do know that the COVID related factors associated with suicide did exponentially increase the overall numbers. We saw this both in attempts and in completions. We also saw a dramatic increase in child abuse and neglect cases that made it to the ER. And you know how relatively infrequent that is. Like most of the time, a lot of that abuse and neglect doesn't make it to an ER. And so we saw quite an increase during the pandemic period. It was really overwhelming, and the CPS workers I know in the field certainly have shared that they've seen the same thing in terms of the intensity and severity of many of the cases they're working on. So more and worse. Wonderful. So we're going to expect that the data that we'll receive at some point for 2020, 21 is going to be much higher. In 2019, though, that 47,000 translated to 130 every day, or 5 an hour. And overwhelmingly, this is a phenomenon that results in more male deaths, or individuals who at least identify as male. They constitute nearly 80% of completed suicides. Any thoughts on why that is? He asked, non-rhetorically.
I've always known that men are at higher risk for some reason, but not necessarily. I don't know why.
Yeah, so the primary reason appears to be that they're more comfortable with lethal methods, or more lethal methods, I should say. When we look at suicide fatalities by the means used to complete suicide, firearms are the clear winner, and there's still a bit of a gender bias in terms of comfort with firearms. By choosing more lethal methods like firearms relative to females, and bear with me, we've got binary data. That's all I can really speak to. So that's just kind of a limit of what we're working with currently. But generally speaking, women not only prefer methods that have a lower lethality, such as overdoses, exsanguination, that is cutting their wrist, for example. But interestingly, one of the main reasons they prefer those methods in interviews with survivors is because they were concerned about what type of mess would be left for the person who found them. So think about how warped of an impact of gender normalization that really is, that even in that moment, their last moment of their life, they're so socialized to perceive that they have to maintain like clean, orderly, tidy environments. Like it's really incredibly disturbing, right? And with men, oftentimes the reality is that they're not doing some of the pre-indicators, what we're going to possibly call gestures, that is behavior that looks like a suicide attempt but actually has a much lower likelihood of being lethal, and it was intentionally chosen as such. Historically, we've sometimes referred to this as a cry for help, but that's often a really pejorative way to look at things, right? So when we call a suicidal gesture a cry for help, what we neglect to really recognize, and we're going to get into more of this a little bit, what we really fail to recognize is that those individuals had to cry for help because asking for help wasn't an option, because they weren't going to get attention relative to their need doing something else necessarily. And it's an important issue, and it's actually something that, at least within the world of working with children, adolescents, especially those in child welfare, you can't necessarily count on them having the same opportunities to just, hey, I'm having a bad day, I need a hug, and for that to actually result in getting a hug, to ask for nurture and receive nurture. That's not necessarily something that's going to happen. So gestures do become more common. Our advances also in, emergency medicine and even like first responder medical training really has resulted in a lot of people surviving things they might not have survived 25, 30 years ago. So taken together, those are the generally accepted explanations for why we see many more males completing suicide, even though females actually attempt suicide about 6 times more often than males do. Michigan, we fell in kind of that medium high level in terms of our suicide rate relative to other states. Now, not all states report on their suicide data, but our number in 2019 was almost 1,500. That's a substantial number of suicides. And part of what we're going to look at is what's the relationship to completed suicides. And by the way, does anybody know why we use that term? Maybe this is the first time you're hearing it, or you've heard it other places, suicide completion.
I do intake for a psychiatric facility, and it's my understanding that there's so many other terms, like there's interrupted, there's aborted, it just to kind of give it a little more understanding on what actually happened, because it's different than saying that someone attempted suicide, had a suicide attempt. They have officially ended their life.
Exactly. And, we want to talk about suicide not as a distinct event, but rather a range of behaviors. And we're going to get into that in a moment as well. But we also want to avoid talking about somebody who takes their own life after they attempted and their attempt worked. We don't want to say they successfully committed suicide, right? Generally want to try to avoid using the term success and suicide even in the same paragraph. So the term completion is used to both help, like you offered, Alicia, to distinguish what happened in terms of the range of suicidal behaviors, but also to be able to discuss this without having to use terms that oftentimes appear insensitive, essentially, right? They successfully completed suicide. Like, nobody wants to say that. So that's where that word completed comes from. In the US, suicide is the 10th leading cause of death overall. But when we look at different age groups, it varies in where it falls. Among 10 to 34-year-olds, it's the 2nd leading cause of death. And if we look at, the population as a whole and just narrow that down to 16 to 24-year-olds, it's the leading cause of death. This obviously is going to have some variance by race and ethnicity, but the 2nd overall. 4th leading cause of death for 35 to 45-year-olds, and 5th leading cause of death for 45 to 55-year-olds. So this is a significant issue. And one of my favorite rants to go off on, since we're in a CEU training, is that every time there's a hot topic issue in the past decade, it seems, we add CEU training for it, right? So we got excited about people finally discovering there was an opiate problem in the country, and then mandated pain management, right? Then we mandated now the implicit bias training and the human trafficking training. And every time we do that, I'm like, well, that's great. But you do remember that while you were writing out your explanation for why we're going to change our CEU requirements, that 130 people probably died from suicide, right? Like, we probably want to focus a bit more on this, right? If we've agreed that this is a growing problem, maybe we should do this. But apparently we're not there yet. So I'm even more excited to have you as a captive audience for a couple of hours. And when we think about why suicide is such a big deal, it's because there's this perception that these are completely avoidable deaths. And what I want to say about that is many suicides, I might even go as far as saying most suicides are avoidable. But the idea that we could prevent every suicide kind of goes against the nature of suicide, which is there's still at some point a volitional act on the part of an individual. So do I believe that we can dramatically reduce the number of suicides? Absolutely. Do I think we can eliminate them? I don't. And when you think about, and we'll look at this more in a minute as well, think about kind of what we know about the relationship between mental illness and suicide. Taking a look at the population as a whole, about 50% of individuals who live with major depressive disorder will make some type of suicide attempt over the course of their life. And about half of them are estimated to actually complete suicide, which then statistically would say you have a disease called depression with a 20% fatality rate, which is higher than many forms of cancer. So understanding that, unfortunately, part of what goes into suicide is, a disease process. I don't think we can complete all of them. But when we're talking especially about children, when we're talking about young adults who oftentimes they're the victims of their own lack of neurodevelopmental, hardiness. They're still developing the part of their brain, the prefrontal cortex, that gives them impulse control, emotional regulation, judgment. They have a narrow frame of perspective on the world, right? Think about when you were in high school and somebody said, oh, you only remember, that happened 10 years from now. That's over half of your life. Like, that's an impossible time frame, really, to give somebody a reference for. So what we see in children, adolescents, and even individuals in the early stages of young adulthood is that they're more quickly finding themselves in that hopeless and helpless place. They don't believe things will ever get better, and they certainly don't see anything that they can individually do to make it better. And when you have hopelessness and helplessness, you have a suicidal state, right? So suicide prevention efforts obviously need to be very customized to the population. And another recent kind of insight that we found, 20% of all suicides, the individual had opiates in their system. So again, we talk about suicide, we talk about rising rates of opiates, they do intersect. Alcohol has always been a major contributor. Almost half of individuals who complete suicide had alcohol on board at the time as well. So we know suicide and substance use highly correlated. And when we look at it and compare it to homicide, just going back over the last 10 years or so, what we see is that homicide has remained relatively stable, right? The variance in it has been relatively minor. And if we backed up and looked at like a 40-year trend, what you'd see is that homicide has been dramatically decreasing, which often doesn't feel like it's the case, right? I mean, you watch the news and like it gives you the impression that we can't wait to kill each other as humans. But it turns out we actually have been killing fewer of our fellow humans than historically, at least on a one-to-one basis, right? Suicide, on the other hand, you can see that there's been an actual like steady increase. And I want you to pay attention specifically to 2013, 2014, because we see kind of a movement where there's a plateau and then a movement there, and then again in 2016. And part of what we're actually able to do now is look back and see how do events that affect, let's say, parents actually catch up with children. And so when we back this analysis up a bit longer, what we see is that there's a spike in suicides around 2008, 2009 for adults in their 30s and 40s. And then when we get to 2013, there's a bump in suicides related to adolescence. Why do you think that there's this kind of relationship between an increase first in parent age individuals and then increase in children? I know you're thinking it. So you were probably just now thinking, oh, I wonder if it's because the events that actually lead to a parent feeling kind of that sense of hopeless and helpless, like 2008, 2009, wasn't that when the rest of the country really experienced the brunt of the depression or the recession? Yeah, as a matter of fact, it was. And we see, people starting to lose jobs, then houses, relocating, all that stress doesn't catch up to the children necessarily for a couple of years, and then it hits them, right? So there's kind of this trailing effect where children, receive kind of the brunt of some of these social risk factors that occur a little bit later. And this is helpful to know because, when we think about suicide prevention, for better or for worse, there have been some actually fairly predictable like variations in suicide. And if we could recognize that and respond to that ahead of time and really get in a better place to meet that demand, we would probably have quite a significant effect at reducing the number of suicides, especially among younger people. And I want to talk about some of the risks just unique to child welfare work. Historically, we have not done a ton of research specifically on suicide among children, either referred to CPS or under CPS care, removed from the home. For whatever reason, we haven't. Fun fact, the country leading the world in terms of doing research like this, Canadians, which I suppose makes sense, right? They're super nice, so of course they're going to care about this issue because it affects children. So that's my explanation for why Canada actually has produced the vast majority of research. In fact, a lot of this research literally is hot off the press. So Palmer, Prindle, and Putnam Hornstein actually published a piece just last year. And they were actually doing research looking at children living in California at the time. So they got secondary data from the state of California, started following them if they were born in 1999 or 2000, and identified whether or not they'd had some contact with CPS. And by contact, simply meaning that there was a report made, an allegation. And what they found was that when they looked at CPS involvement, meaning there had been some history of an allegation, versus non-CPS, there was an enormous difference in suicide risk and behaviors. In fact, over half, 56.5% to be precise, of the adolescents who completed suicide during this time had a history of CPS referral. I want you to think about that the kids on your caseload, over half of them potentially could take their life. I mean, that is a stunning risk factor. The only other place we see such an disproportionately high burden associated with a single risk is among individuals who identify as transgender. That's it. Like, this is astronomically high. And what they generally were able to find by comparing the two groups is that having any type of CPS referral increased your risk of completing suicide by a factor of 3. And what's going to be really important to keep in mind is that this is a 3-time increase in completion, not in suicidal behavior in general. I'm going to get to that in a moment, but suicidal behavior is far more common. Okay, so just completions alone. And here was the interesting finding as well. it didn't matter if the allegation ended up being substantiated, and it didn't matter whether or not they were removed from the home. So help me make sense of this. Why do you think suicide risk did not increase based on substantiation or based on removal?
You can feel free to unmute or write in the chat.
Or you can put up, I think there's a middle finger emoji. You might have to download this separately, but it's like, it's just too jerky to even expect you to chime in with a virtual presentation. My bad. I enjoy this. I enjoy the interaction. I look forward to even getting a chance to learn from you as well. So I'd be especially curious to hear from some of those of you who've been in the field longer and what you've seen in terms of, like, you know.
I think one of the reasons would be, even though there was no substantiation or placement, the abuse is still occurring within the home and no one's able to help them because it's not being substantiated.
Yeah. In fact, I think that actually, Holly, I think that probably nails it. When an allegation is made, substantiation, we know, is not a guarantee. And we know that even when you have what would be considered a lot of evidence, it's not very cut and dry. And so in many ways, maybe the explanation here could be that sometimes having a little hope and then being disappointed is worse than having no hope at all. Because what's interesting is when we look at children who just experience maltreatment in general, we find something actually interesting, that they, as a cohort, for lack of a better term, actually tend to develop more stress hardiness, and essentially they become survivors just by virtue of what they have to go through. The truth is that virtually all children make it to adulthood now, despite the horrendous things that they might experience. And I was kind of fascinated a few years ago when I was seeing some research that actually came out of the Department of Defense. This specific research was trying to figure out how do you better identify individuals who would make good soldiers for elite units. So we're thinking like the top tier military special forces. And through more anthropological work of, you know, interviewing and going back through an individual's history, and observing kind of, you know, group behaviors, group dynamics, and that, they recognize that the key element obviously is stress resilience, right? Your ability to tolerate distress for prolonged periods of time. And what they found was that virtually all of those individuals in these elite units experienced some significant childhood adversity. And ultimately, it provided some type of inoculation, if you will, and resulting in some type of hardiness. And this is an important consideration as well, because we've been talking a lot about trauma-informed this and trauma-informed that. And I do a lot of work with individuals who've experienced trauma as adults. A little bit more about me: I'm also a reserve police officer, and I do a lot of work with first responders. And what's interesting to me is that a lot of the talk that happens around trauma-informed is trauma's bad, and people go through trauma and it changes them and it's bad. And okay, that's sometimes true, but actually what also happens in trauma is things like, you know, traumatic resilience. We see vicarious resilience. We see a host of other things develop. And when we consider how common trauma is, that among adults, over 90% of the population has experienced some type of trauma at some point, we know that it's not trauma in of itself. It's the context of trauma. It's the amount of trauma and the, you know, how long trauma was prolonged. It's even the context of trauma. It's way more nuanced than I think we often give it, credit for. And so imagine when you don't have any hope, you find ways to persevere. And it's phenomenal that as humans we have that ability. We pay a price for it in the long term, certainly, but it's remarkable, right? But what happens if somebody tries to help and then it doesn't work? Sometimes it's almost worse. Sometimes it's almost like, well, now I'm not going to trust that people will help or can help or anything can be done. And here's what's more scary. There's some evidence to suggest that when people reach out for help and it ends up not being very helpful, it decreases the likelihood that they will ever ask for help again. And this kind of ties in with a little bit of what I mentioned earlier about what I often see in the emergency room when individuals, especially children, arrive there because they made some type of suicidal statement. Right? Either they admitted that they've had the thoughts or they threatened to do it. Schools have kind of adopted a policy where you're going to be sent to the ER if the word suicide ever comes up, and you can't return to school until you've been cleared. I had a lot of private practice social workers send clients. They were in the session, the client admitted to having some suicidal thoughts, and the clinician's like, okay, you have to go to the ER right now. And the problem with that, aside from, kind of overloading a finite resource, is that the ER is not a great place to be if you are actually like feeling that way, right? It is going to be a more chaotic environment, which is not likely to make you feel better. The delay is going to be extensive. And I can tell you that I've worked at two of the busiest ERs in the nation in the course of my career. And it is not uncommon to have wait times that, can be 36, 48 hours just to be seen by, one of the psychiatric social workers for the assessment. And what I hear more often than not from children and adolescents in the ER is that they feel like they're being punished because they admitted that they felt a certain way. And as a result, they'll also often make statements like, I'm never going to say this again. I'm never going to talk to that counselor again. I'm never going to do this again. So we know that there's a big discouraging factor that often occurs on the part of the actual individual who was seeking help and didn't get it, right? And it puts an enormous burden on you in the child welfare system, because oftentimes you're one of the only sources of professional contact, at least early on, that the children and adolescents are going to have. Even though they might be in a school that has resources, we know that children learn there are rules when there's this type of behavior going on at home. Things you don't see, you don't hear, you don't talk about. And children learn that they have to, obey the rules or the consequences are dire. So you actually have this heightened burden for a population that's got heightened risk. Another couple of studies that kind of get to this issue is really kind of reveal that it's not just completions that increase, but the wide array of suicidal behaviors also increase, as do other associated risks of harm. So suicidal behaviors, including ideations, plans, and attempts/gestures. All of those increase dramatically among children who are experiencing any kind of maltreatment. We know that young children especially are susceptible to the influence of neglect. In fact, neglect actually seems to be far more severe and a greater predictor of any type of self-harming behavior than actual physical or sexual abuse does. Why do you think neglect for younger children might be so much worse than physical or sexual abuse?
I think with neglect, they are missing something maybe. So I think the increase of self-harm, a lot of times when you're self-harming, it's because you're feeling inner pain. So you harm, I'm thinking like of a cutter, you harm so you don't feel that pain anymore. And when you're feeling being neglected, there's a fine line there of a lot of pain, if I'm making sense. Does that make sense?
Absolutely, absolutely. And I personally think you're dead on there. So the reality of what the experience of neglect is like, in terms of that, that connection to the others, the responsible others in your life, that dependence in many ways on them, it really kind of casts the whole world into uncertainty and often leads to a greater sense of being out of control. For better or for worse, children who are the victims of physical abuse usually all handle it in the same way. They adopt a faulty belief that they're just bad. Why are they beat? Because they're bad. They're bad kids. And that actually gives them some sense of control over the world, even though they don't have it. But what we see with younger children who experience neglect, because of their greater reliance on adults for everything, for food, for housing, for the most basic needs, is that it makes the whole world seem unpredictable and unstable and keeps them at such a heightened level of discomfort that they're going to find some way to have control over something, often in their own bodies. And what's interesting is that all of these things, really don't just work in one direction. So I've talked to quite a few parents in recent weeks about, how do you talk to your kids about, things like war, and hearing things, in their friend groups, seeing stuff on social media, like, are we going to be invaded, or what's a nuclear holocaust? 7-year-old asked that not too long ago to a parent I talked to. What I really try to emphasize is that when there are these traumatic events occurring, the younger the child is, the more they kind of look to the parent. And if the parent seems like they're stable, they're able to get things done, they're able to make it okay, kids actually can be really okay with that. So again, it's that power of, that relationship at that age. And, it goes in either direction. It has the ability to be protective or to do great risk. Now, neglect becomes less significant in terms of suicidal behaviors as children get older. In fact, by the time we get to adolescence, then abuse actually has a much higher correlate, and actually sexual abuse takes on a much bigger role. In fact, one of the things we know about sexual abuse among younger children is that rarely do they recognize it as any form of abuse. I remember years ago, I was working in a partial hospitalization program, and there was a 23-year-old in a group I was leading who recounted the first time she learned that she was being sexually abused. She had gone for her first sleepover at a friend's house. She was 12 at the time. And she got to her friend's house, and they're hanging out and playing. And a little before 9 o'clock, her friend's parents came to the room and said, "All right, it's time to go get washed up and brush your teeth, and then we'll be in to tuck you in." My client reports that suddenly she was filled with a sense of panic and dread and felt like she had to get out of there. And her friend's like, "What's wrong with you?" And she panicked and actually jumped through, luckily, a ground floor window in her friend's room, jumped through the window and started running down the street, ultimately resulting in the police having to pick her up. And when she was finally able to talk about why she was so upset, she's like, "I don't want them to tuck me in. That's what my stepdad does. I don't want anybody else to do that." Tucking in was what had been happening to her for the last 10 years of her life, almost every night. And again, it wasn't sexual abuse because it was normal. This is just what happened. And so she, even if she had been asked, "Does anybody do anything that hurts you? Is somebody harming you?" she couldn't have responded that she was, right? And we know that that's one of the biggest risks in even the language we choose sometimes when we're interviewing people, right? you ask if somebody's abusing you, you'll get a lot more people saying no. But if you ask, does anybody try to control you or manipulate you? Does anybody grab you, kick you, punch you, pull your hair, physically restrain you? Well, yeah, but not they don't like abuse me. It's not like they never broken a bone. They've never done this. Abuse is often something else, and that's even to adults, but especially to children in the context of sexual abuse, it's so normalized that they don't recognize it. And oftentimes why it becomes more significant in adolescence as well is that many sex offenders, some would argue most, are preferential. And so they don't have an interest in somebody who's going through or has gone through puberty. And oftentimes what you'll see is, adolescents suddenly start acting out right around puberty. And one of the first explanations is always like, oh, it's hormones. But it's always worth more investigation if it's a more severe kind of behavioral manifestation, because oftentimes it's the chaos, confusion in their life because this normalized event, this sexual abuse they've been experienced that they didn't know was sexual abuse, suddenly stopped. And they experience it very often as a sense of rejection or like loss. And not that they liked what was happening, but it was so normal. It's like, well, what changed? What's going on? Why are you different toward me now? And again, it starts to play a much, much greater role in terms of its relationship to suicide risk behaviors. Another group of authors actually found that children who grew up with any kind of contact with the child welfare system were, as adolescents, 5 to 8 times more likely to be hospitalized psychiatrically, right? So not only do they have some type of mental illness, depression, some type of anxiety disorder, but it became so persistent and pervasive that it limited their functioning, and they ultimately ended up having to be psychiatrically hospitalized for it. And this effect barely diminished when they got into young adulthood. It remained 4 to 6 times higher. And so part of what we see here is that the maltreatment not only directly increases your likelihood for suicide, but it increases your likelihood for other adverse outcomes that are related to suicide. More likely to develop, a psychiatric disorder that increases your risk of suicide. And last but not least, your job isn't just to attend to the children. It's also considering the entire family system. And we have a little bit of research on the effect that contact with CPS, specifically having a child removed, what effect that has on mothers. And I could only find one study that actually directly addressed this. Multiple studies talked about, reactions, risk of relapse, et cetera, that occurred among mothers, but this was the only one specific to suicide. And in this study, again, a Canadian study, what they found was that compared to female siblings, that is their sisters, women who had children removed by child welfare services had a net increase in the risk of suicide attempts and completed suicides. So just to kind of summarize all this, you have arguably the hardest job within all of social work. You have all kinds of risk factors that make it hard to pin down who is more at risk or at a heightened risk because of them in terms of the children and in terms of the parents. I am relieved only in knowing that you are so incredibly well paid that it kind of makes it all wash out, right? I appreciate what you do. I admire what you do, and we need you. Another time, maybe we can have a chat about what doing this type of work actually does to you. I see that in this series, there are some other people are going to talk about secondary traumatic stress, vicarious trauma, but you're as at risk for that as anybody on the planet. So one little plug I'd like to give. I believe that self-care is of the utmost importance. And I'm all for boa baths and yoga and whatever works well for you. But one of the best forms of self-care the absolute best forms of self-care, having a therapist, honestly, like having somebody that you can actually talk about your day. Because let's face it, when somebody asks you in child welfare, how was your day? They don't want to hear how your day was. It would upset them. It would definitely spoil dinner. Okay. So we know this. And what we often find among individuals, you know, working in child welfare, working in other very like intense roles within the broader social work field, where they see a lot of human suffering in that, is that they really don't have people that they can just share this with and discuss this with. And a therapist is a great person to help you with that. I remember hearing in grad school that every good therapist, every good social worker has a good social worker. Every good therapist has a good therapist. And just like to encourage you to, you know, reward yourself, like indulge, if you will, in that gift to yourself as a form of self-care. Off soapbox. So part of what we have to figure out then, when we're just facing, you know, all of this potential for, you know, our clients to be suicidal, we have to figure out how to make sense of it, how to filter through with it, and what to do. Because as I kind of mentioned, sometimes doing something might not be doing the right thing. And many things are not benign. Like, you know, the idea that like, well, it can't hurt to send them to the ER, it can't hurt to do this. Well, in fact, it can. It's a fight I have very often with physicians who are like, you know, I'm not confident that I know they're not going to go home and complete suicide, so I want them hospitalized. I'm like, well, I'm relieved to hear you're not confident in that, because that would mean you could see the future, and you know, like I would think you'd be doing better for yourself even than, you know, the success you've attained, right? Like none of us know that. Like you never can predict what somebody's going to do. And often what we do is confuse this idea of suicide prediction with suicide assessment. And when we talk about these topics, it's important to recognize that they're vastly different. One is an academic event, essentially, and the other is actually an intervention. Prediction merely refers to a statistical probability, right? And it's really a problematic field because it does not translate very neatly and evenly into behavior, because behavior is far more complex. So, for example, we know that there's a correlation between prior attempts and completions. But having made a prior attempt does not make you at any given point in time at greater risk for suicide. And often what's happened is many of the suicide risk assessments, so not really like the clinical assessment of an individual, but the screening tools, suicide screening tools that are used to kind of identify who might be at risk. These scales dramatically over-identify people as being at risk because of some of these statistical, you know, realities. In fact, there was one, and some of you may even come across this before, called SAD person. Essentially, in this tool, by virtue of being male, you were going to reach a clinically significant level in terms of your risk and need for intervention. Because prediction is looking at how these things might relate in some way. And it often leads to over-identifying. And the truth is that, yeah, these are things that we have to keep in mind when we're looking at what's going on. But if we don't address them properly and in the context of what the individual is currently facing. And when I say current, when we're talking about suicide, I mean 24 to 48 hours. We're looking at narrow timeframes here, because when a person is truly suicidal, they're in a crisis state. And crisis states are by definition short-term. In fact, the definition of a crisis is you've exhausted your psychological ability to cope with the demands you're facing. Nobody can sustain it. And it tends to be very short-term. It's somebody entered it because of the straw that broke the camel's back. And often they come out of it because one thing can get, slightly changed or fixed. For example, I don't know how many people I've seen who were acutely suicidal. They wanted to die. And I did mobile crisis teams for many years. So I'd actually go out to the community, to a parking lot, wherever the person was, and do these types of assessments. And I was able to actually get them from, I want to kill myself right now, to, okay, I can figure this out by doing one thing, getting them cigarettes. They'd run out of cigarettes. Smoking was their primary coping mechanism. And while it's not a healthy habit, a coping mechanism is a coping mechanism. And a bad coping mechanism is better than no coping mechanism. Now, obviously, over time, we want to help somebody transition to healthy coping mechanisms. But if you smoke to manage everything that's going on in your world and you run out of cigarettes, you're in trouble. So conversely, you get those cigarettes back and now you're going to be okay. And I point that out because it's actually really great news, because oftentimes when we think about suicide, it's this enormous, scary, gigantic problem. But the actual moment of people being suicidal and actually considering it is such a narrow window. And often they got into that situation because of one last thing, right? And often the straw that breaks the camel's back is in and of itself insignificant. It's only meaningful in that it was the last thing that that person could tolerate, right? So if it's that close to end up in the state, it's actually that close to get away from it, right? It's 1 foot over the ledge and 1 foot away from it. So that's good news, because what that translates into is that often what we consider to be very little things have enormous impact in terms of actually reducing somebody's suicidal behaviors, increasing their perception that they can do something different, that they have something better to look forward to, like increase their hopefulness, decrease their helplessness. I included this, and Chantalia will at some point make these slides available. So if you're having any trouble sleeping, you can go through them, and hopefully I can be helpful to you in that moment as well. But one of the best articles on this topic of prediction versus actual risk comes from Fowler 2012. And the author does a great job of really breaking down how these individual, variables actually predict a suicidal behavior. And it turns out that it's far less, direct than we're often led to believe. And so what we want to think about again is, you encounter somebody that either does express some type of suicidal thought or exhibits some type of suicidal behavior. Your time frame needs to be more narrow, not like, how do I keep this person safe for the next 4 years? It's, what do we do to get through the next 24, 48 hours? What's my confidence that this person would be fine without a greater level of intervention in the next 24, 48 hours, maybe 72 if we're looking at a long weekend. And essentially, by improving the type of clinical judgment you apply to these situations, you have a chance to really, first improve the safety overall of the client. Because, getting good information, doing a quality assessment is going to give you a lot of valuable information that will allow you to not only intervene, but create a series of interventions that will help protect the individual now, and hopefully, if this happens again in the future. And it's also going to protect you as well. By using evidence-based practices, not only do clients do better, but we do better. We were protected from having malpractice, and more importantly, we're protected from having made a mistake that we would have to live with. And most of us don't want to try to live with a mistake that involves somebody being hurt or dying, right? It's not really part of our social work nature. And this is the general model that we're going to kind of talk through. And it's kind of the most accepted model in terms of how do we effectively do this. But I want to just kind of give you a quick overview, and then I think I owe you a break. Is that correct, Chantalia?
Yes, we can take a stretch break after this one.
Okay, perfect. So when we talk about the assessment, you know, what we're really looking at are three main things. What is the individual's risk factors? And we're going to divide those into those that are modifiable, things we can change, and those things that we can't. What protective factors do they have in place against suicidal behavior? And then what currently are they doing? Like, what's their actual suicidal behavior now? Are they just thinking about it? Do they have means? Is it a lethal, you know, plan that they have, or did they not have any plan at all? Like, we need to look at all of that. And by considering those three things, it gives us a host of opportunities and allows us to determine what we need to do next. And oftentimes we get too fixated on the risk factors, especially the ones that we can't change. And we forget that if you can't change a risk factor, often you can add a protective factor to change things around. And one piece of hopefully good news for you is that your very presence, especially for your child and adolescent, you know, clients, your very presence is a protective factor for them. So you don't have to do anything magical. You don't have to have the right, you know, thing to say. Your literal presence is a protective factor. There. So that's some great news that you can use while you take a break. So how long do you want to take, Chantalia?
I think 5 minutes is good. Us to stretch and get a cup of water or something.
Sounds good.
Thank you.
I'll just hang back and hang on here during the break, and if you have questions or whatever, feel free to fire them off. Our stretch break is kind of over. So I wanted to spend a little time now talking about the range of suicidal behaviors. So when somebody talks about suicidal behavior, it's easy to kind of see that as somebody who's trying to kill themselves, but it's bigger than that. It starts with thoughts. We call this suicidal ideation. And suicidal thoughts can either be very overt, like, I want to kill myself, or it can be, I wish I was dead. I wish I'd never been born. I wish that, like, you know, I could just disappear. I wish that the whole world would just end. It can take a variety of forms, and we never want to be too concrete with how we hear people's statements. So on one hand, somebody might not say, I want to kill myself at all, but they say other things that really give you the impression that, like, they would rather not be alive. Well, we've got to respond to that. And we've got to not be so maybe dogmatic that we're like, well, they did not say they wanted to kill themselves. And the other thing we can't be is afraid of asking the direct question. And I don't know how many thousands of times I've asked the question, but I can tell you I still feel uncomfortable doing it. Asking somebody, are you thinking of killing yourself? Oh, it feels like such a violating question. It feels like you're metaphorically stripping them naked and just prying into them, like, in a way that you don't have permission to do. Like, this is too intimate. This is too close, too big of a deal. When I started my career, and to some of those of you who are a bit more veteran in social work, you may have been kind of trained to say, like, are you having thoughts about hurting yourself? But it's important to recognize that that's a problematic question, especially when we look at different generations of individuals. So older individuals often equate hurt yourself would kill yourself. But that is not true for younger people. So best practice is to ask directly. So the way you're feeling, does it ever leave you wanting to kill yourself, wanting to end your own life? And again, don't expect that to feel comfortable or normative. You know, if it does for you, then I envy you. It never does for me. I always feel like I'm intruding, like this is so personal, right? And conversely, I feel like when somebody shares that information with us, that displays a level of need and trust that we want to be good stewards of. And so when we are assessing for ideation, we want to be concrete in what we're asking, but not concrete in what we're hearing, right? So if somebody's like, I wish I'd never been born, then like, I get feeling like that sometimes, but tell me, like, do you feel like you wish you had never been born so much that you've thought about killing yourself? Like, we wanna actually pin them down and get an answer, because there's always room for hyperbole, right? How many times do we casually say things like, oh, I'd rather be dead than sit through another CEU training with a weird bald guy, right? I mean, I know I have that thought probably 50 times a day. No, the reality is that we want to get really specific and pinpoint what they're saying, and not leave ambiguity out there, because especially for younger people, thoughts of do you want to hurt yourself often mean self-injure, cut, maybe burn themselves. And the interesting thing is that there's not a great relationship between self-injury and suicide, because self-injury more often than not takes on a role as a coping skill. Again, not a coping skill that we would want somebody to have for the long term, definitely something we would like to find a replacement for. But a coping skill is better than no coping skill. So a bad coping skill is better than not having any coping skill. And sometimes this gets lost. And I see this especially in the treatment of substance use disorders, where individuals will very often, maybe they achieve sobriety or start achieving sobriety around alcohol, and then they want to clean house, right? They're like, now I'm going to give up cigarettes, and I'm going to go vegan, and I'm going to only listen to, Celine Dion or whatever it is that they're going to like do to kind of like purify themselves, right? But they just gave up their primary coping skill, the primary way that they dealt with life, alcohol. And when I hear them say like, oh, I'm going to give up smoking too, and I'm like, nah, not if I have anything to do with it. Like you don't move too fast. You just are going to guarantee a relapse, right? It takes a long time to find a replacement coping like skill for something that's been that huge, right? Like alcohol, or in this instance, self-injury. Like telling somebody to journal or take a bubble bath, that's not going to provide the same impact. And oftentimes I feel like we're just not being genuine when we throw out ideas like that, right? When we're like, well, why don't you try like listening to music, or do you write poetry? Maybe do that into self-injury. I'm like, oh, like I wanna yell so many bad things at you right now. Like that is not comparable. In fact, I'll talk more about self-injury in a little bit, but we want to just distinguish it, right? Are you having thoughts about killing yourself? I've even learned the hard way, don't ask like, so are you thinking about suicide? I asked that one time, it was an older individual, and they said, no, but I do think I want to kill myself. So I took for granted that everybody knew what suicide meant, but don't make assumptions, right? Something about you making something out of something. So don't do that. Be direct, ask the question. In addition to ideations, we have the category we call threat. And a suicidal threat is merely the communication of the desire to harm yourself. Now, when somebody like posts on social media, like, I'm sick of all this, I'm out, I'm done. One encouraging thing is that we've seen, especially among younger people, they take that very seriously, and they often try to get help for the individual. But when somebody expresses it, and often when they express it in a way that kind of invites like a confrontation of some kind. So often when we talk about a suicidal threat and differentiate it from suicidal ideation, it's like they're not just saying they're suicidal, they're making it clear that like, I want to do this, and almost implying that there's something that's happening right now that's causing this. And unfortunately, sometimes this becomes just a pattern of behavior. We broadly refer to as parasuicidal behavior, right? So they often make threats to get their way. If you break up with me, I'm going to kill myself. If you don't let me go out with my friends this weekend, I'm going to kill myself. And so it can be really hard because, again, they're saying something very concrete, but we have to investigate whether they have any intent behind that. Is this something somebody's saying when they're angry or frustrated, or is this like a manifestation of something else? Gesture. We talked about this a little bit earlier, but to be clear, these are symbolic acts that necessarily have a perceived low lethality. And I say perceived because unfortunately, people have completed suicide when that was not their intention. They had false assumptions about the dangerousness of a given behavior or action. Example, I have fortunately, and I'm knocking on this wood-like substance at my desk, I have never had a client that's directly under my care complete suicide. But that same partial hospitalization program I was working in, somebody that was in our program while I was there, had in a group heard another group member talk about their suicide attempt, and she was explaining, well, I overdosed on Advil, and I did that because I knew it wouldn't hurt me, and I just wanted my boyfriend to like realize that he didn't want to lose me, so I didn't really want to kill myself. The group member who heard this was going through some relationship problems, and that night went home, and when she heard Advil, she thought, oh, pain medicine. So she got Tylenol, because that's what she had at home, and took a whole bottle of extra strength Tylenol. She didn't know that Tylenol is very toxic at relatively low levels. In fact, it's one of the most dangerous things we have in our homes, and it's an over-the-counter medication. Something, by the way, that when we do identify that an individual is experiencing suicidal thoughts, part of a safety plan needs to be kind of inventory. What are the dangerous things in the house? What we know about people who develop a plan is they tend to come up with that plan based on a decision-making matrix where it provided all the right ingredients. Usually they didn't think it'd be painful, or they thought it would be quick and they would, complete without any trouble. And they tend to really, they get wedded to their plan. So oftentimes if they have a concrete plan, it's a little easier to do some safety planning. But that being said, desperate people do desperate things. We had a woman in our hospital on our psychiatric unit try to drown herself, kid you not, tried to drown herself in the toilet in her room by shoving her hair down the drain, believing that if she flushed the toilet, the force would hold her head under the water. So in desperation, there's no limits, unfortunately, to people's creativity and finding ways to harm themselves, to kill themselves. It's potential, and we can't control for every variable, but there are certain things that we can do. So I've learned to make sure that we inventory, houses. Like, so what prescription medications do you have? What medications have you thrown away that you have? Do you have an older adult living in your home? Because I'll guarantee you they've got medicine. Here's another one I learned the hard way. People do not perceive pet medications to be medications. So if you ask, what meds you have in the home, they don't list the pet medications, even though pets are frequently prescribed medications that are also prescribed to humans. I have one of the 2 dogs I have is a husky. I adopted him, actually smuggled him in from Canada during the pandemic. At a time when all of North American dog shelters, humane societies were all empty because everybody adopted. There was one unadopted dog, and it's because he has epilepsy. So he requires medication and a lot of support. And I felt comfortable, and my wife and I felt like we had the means to do this, so we did that. And the medications, one of them specifically, is incredibly dangerous. Like, it would take very little of it to result in death. In fact, most medications have what's known as an LD50 rating. LD50, which stands for the lethal dose at which 50% of people who took it would die from it. Now, something like Advil, the active ingredient, ibuprofen, astronomically high LD50, like, be pretty hard to kill yourself with that. But Tylenol, a healthy adult liver can only tolerate about 2 milligrams a day, which is 4 extra strength Tylenol before it can start impacting the liver. And this client at our partial hospitalization program didn't know the difference. And as a result, she ended up dying 3 weeks later after learning that she was going into liver failure, and no liver transplantation wasn't an option because attempting to kill yourself was a disqualifying criteria for the universal donor list. And one of the worst days of my professional life was when I was sent to actually go and talk to her, because it was new and everybody knew it was a growing experience I needed. And hearing her beg and plead with me and explain, like, tell them I didn't really want to die. I just wanted my boyfriend not to leave. I don't want to die. I don't want to die. Horrifying. Like, truly one of the worst things I've professionally encountered. And knowing there was nothing that could happen, that she was going to die. I had no intention of doing that. So medications in the home, inventorying them and asking, how about pet medications? Over the counter too. What supplements do you have in the house? Really being specific about that, because I've seen a lot of overdoses in my ER that were on pet medications. Trazodone is commonly prescribed for dogs, similar to how it's prescribed for humans for sleep or for a sedative effect. It's an old antidepressant, but it doesn't take much of it to actually create potentially fatal heart arrhythmias, a condition known as torsades de pointe. And sorry, I know I'm getting a little too nerdy here, so I'll dial it down a skosh. But the point is that we want to, when they express the threat, we want to take that seriously. And when we're thinking of the plan, we want to get to the heart of what are they thinking of doing and what are the dangerous things in the home. Right? We've done better about trying to figure out, does the person have access to a firearm? That's an important step. But we also need to, take very seriously the medications in the home if they're a definite risk. So gesture, and keep in mind, the only way to distinguish a gesture from an attempt is to find out what the person's intention was. So somebody could, think that something was completely non-harmful, like that client at my partial program, and inadvertently have that lead to, completion, or they could believe it was very dangerous and it really wasn't. I've had a lot of, especially adolescents and children, who their suicide plan was to take an overdose of gummy vitamins. And here's a little pro tip. We don't correct that type of misunderstanding. That's what we call a side benefit protective factor, right? That they're not quite learned enough to realize that the gummy vitamins might give you a cavity, but they're not going to actually result in you killing yourself. I feel compelled to just remind you, you should never point that out. Be like, oh, that's you can't kill yourself that way, or certainly don't challenge what they're saying was their desire, right? Just because it doesn't make sense to us, don't challenge it, because often it's heard as a challenge, and sometimes challenge accepted, right? And I've heard clinicians do this where they're like, I don't think you really wanted to kill yourself, because if you had wanted to kill yourself, you would have done something that would have actually killed you. Don't do that. Don't do that, because I assure you there are a lot of people who really do think that random things can, kill you that can't. And we want to, it's protective, so we leave that in place. Also helping this, by the way, is the fact that now if you try to Google, how do I kill myself? The first thing that's going to come up is going to be the number for the National Suicide Hotline. Don't get me wrong, there's still plenty of places on the internet where you can find people more than happy to give you tips and advice, but it's not like it was even like 5-10 years ago, when you would get links to different like discussions of like best medication to make sure you die. Like that's gotten harder to access, at least with most of the major search engines. So they might not have this information. And again, we don't question information that we've accepted. So if you accept that any medication is dangerous if you overdose on it, then you just apply that broadly. So you legitimately believe that, everything has an equal chance of being harmful. It doesn't. Watch for the Tylenol, ask about the pet meds. Aspirin's another one that can be really dangerous. Old medications that haven't been thrown away. We need to do better about this, because we've got houses filled with, grandma's old medications, or, oh, I was given a script for this, but I didn't take it, but I got it sitting in my bathroom for reasons I don't know, because I paid a copay for it or whatever. We got to do a better job of educating people that they need to get rid of those, that they can take them. Most police departments have a program set up to help you safely dispose of them. Don't want to flush them down the toilet, because we reuse water, and we found a lot of Prozac in public water supplies. Not enough for a therapeutic benefit apparently, but it's present there. So don't flush it down the toilet. And then finally, the last of the range of behaviors is the attempt, and that is the intentional, serious effort to end one's life. And for it to be an attempt, all it has to be is the person had this goal in mind. And I've seen attempts that had no potential lethality, and I've seen, people survive things that you don't know how they did, including self-inflicted gunshot wounds. The reality is that, again, this is a good thing overall, that humans are remarkably resilient from a biophysical perspective. And so we're able to tolerate a lot of things, and combining that with improvements in first responder care and emergency care, and people survive things that they might otherwise not have survived. Now, when we talk about this range of behaviors, how does this translate into actual subsequent behaviors? Because it's easy to look really at this and say like, okay, so ideation leads to the threat, to the gesture, to the attempt, and then to the completion, but it's not quite as linear. And so one of the first things we want to do is get a sense of how common are some of these events. So again, if we go on, our data from 2019, that a little over 47,000 suicide deaths occurred in the US. What we know is that the number who admitted to having serious suicidal thoughts is far higher. In fact, the number might astound you. The number was almost 12 million. And unfortunately, that only covers adults, not adolescents. Although what we find in adolescent population-based surveys is that 30 to 40% of adolescents actually answered, yes, I seriously thought about suicide in the last year. Specifically talking about the youth risk behavior survey that the CDC helps coordinate on an annual basis. So suicidal thoughts, enormously common. And what I want to kind of pause and think about for a moment here is that this probably should tell us something about the actual relationship between suicide, like attempts, and thoughts. And the relationship is that it's not as strong, right? 12 million adults alone admit that they've had that thought, but far fewer did anything beyond that. And I think this is good news. In many ways, it's something that we can use to help normalize that, you know, having a suicidal thought is not in of itself indicative of a deeper mental illness, certainly not a weakness. And many of you in the comments had rightfully pointed out how stigma plays such a role in discouraging help seeking and discouraging openness and honesty, which can combine with the wrong interventions and really exacerbate the problem. But think about how, you know, if 12 million had the thoughts, you know, just in terms of adults, and 47,000, like that ratio is very low. In fact, 12 million would be about 5% of the adult population. So 1 in 20 adults did. That's a lot, but it also helps us, again, remember, this is more common, and this is something that, you know, we don't have to immediately pull the alarm and say, you had the thought, you're going to do it, we need to take immediate action. It gives us room to breathe, right? It means that we can respond to this without only responding to the worst case scenario. And often that's what ends up happening, right? So somebody says suicide and we envision them ending their life, and we respond to that as opposed to what we're actually encountering, which right now is just the thought. Now, 3.5 million people, and again, we only have concrete data for adults, 3.5 million adults actually made a suicide plan last year. And what I'll tell you is that having a plan definitely increases the suicide risk. In fact, for a long time, it's been considered one of the best, you know, predictive pieces in terms of a person's actual likelihood of completing suicide. And it is very strongly related. But again, 2 things to point out. 3.5 million made a plan, 47,000 completed. And that number 3.5 is much higher because that doesn't include anybody under the age of 18. Also pointing out the direction in reverse, of that 12 million that had adults who admitted to having suicidal thoughts, you know, not that many, only, you know, about 1 in 3 of them actually went anywhere beyond that. So essentially 70% of people who have a suicidal thought, that's going to be the extent of it. Now, I point this out, and again, I see something very consistent in adolescents and children. The truth is, thoughts are common. Thoughts are not something that we have to immediately get really up in arms about. But if it does make it to the next point where there are plans, now we have to start kind of considering things a little bit differently. We'll get back to that in a moment. Now, when we look at actual suicide attempts, and this is going to be data that comes from reportings, either individuals who report a suicide attempt, and it's compared to any data we have from, you know, hospital admissions. That number is far smaller. It's about 1.4 million. Now, the tricky thing with attempts is that if we're not getting the information directly from the individual, it's hard to actually know how many attempts are happening, because as I explained before, a lot of people's attempts were actually gestures. A lot of people's gestures end up being attempts and they complete. What I've found generally is that there's, especially in younger people, adolescents, there's often more attempts than anybody knows about. And what I've found is that adolescents very often have made attempts that they told nobody about that didn't work. For example, they tried overdosing on something, they fell asleep, they woke up, and they went on with their life. They never told anybody they did it. And part of what is really terrifying about that is it means that we don't really always know, especially with adolescents, how much of the information we're getting is accurate. It also tells us that they might not follow the same kind of trajectory through the suicide, range of suicidal behaviors as an adult would, which makes sense based on what we know about where they are developmentally, right? Impulse control, not their jam, right? Adolescents, in many ways, when you think about, adolescent brains and where they are in terms of their neurological development, they're all essentially psychopaths, right? Like, if we compare what impairment we might consider serial killers have and compare it to the average adolescent brain, not as many differences as maybe we would like to think and really have a degree of comfort in. And while I'm not in any way saying that most adolescents are serial killers, in terms of impulse control, in terms of the ability to really recognize and relate to others, the ability to regulate emotions, engage in high order thinking, the same impairments they have because of their level of neurological development are the same key characteristics we see in individuals with some of the most severe antisocial personality disorder, right? So never lose sight of that with adolescents. But when you're highly prone to impulsivity, it remains this kind of X factor that we can never fully control for. And we'll see how much that might actually play out in just a moment. Now, getting back to the number of suicide attempts that were reported, assuming that this number is within the ballpark of being accurate, it amounts to about 40% of those who made a plan. So part of what we see there as well is that making a plan definitely is concerning, definitely requires something more be done. But it itself is not a guarantee. In fact, you've got a better chance than not of not making an attempt if you make a plan, statistically speaking, right? And again, we're not going to rely purely on statistics, but part of why I like to share these numbers is because hopefully it gives you better context so that you can feel a little bit more confident that you don't have to escalate things maybe beyond what's necessary in the moment. You can use your clinical judgment. You can do your own assessment and make a plan without feeling like, oh, this is automatically going to go here. Because the truth is, it won't. It won't. And finally, the actual completions, the 47,478, it amounted to about 3% of all attempts, which actually, believe it or not, is a little bit down from where it was 10 years ago in 2012, where it was around 3.5%. So again, attempts, because of how a person does it, because of what interventions are available, even attempts don't translate into suicide deaths very concretely and neatly. We need to address them, we need to account for them, but we don't need to adopt this is going to happen and automatically this is going to happen. That's just not how it works. I also want to kind of take a look at what we know about adult survivors of suicide. And this is based on data from 2018. And here we see some of the same numbers we were talking about before in terms of suicide attempts and plans, serious, plans with an attempt, serious thoughts. Let me kind of break down this image for you because it can be a little bit confusing at first. So when you look at the number, the circle that is blue that includes that little sliver of green, there we're talking about that proportion, that green circle in there with the blue circle amounts to the 3.3 million individuals who made serious suicide plans, right? The larger circle of gray is who had serious suicidal thoughts. So thoughts, actually plans. So now let's look at just that green portion of the blue circle, they made plans and attempted. That was roughly 11% of people with ideation, about 1 in 10. So 9 out of 10 people who had suicidal thoughts in 2018, that's as far as it went. So again, the thought itself does not need to trigger a all-out alarm response from us. And in fact, if we handle that situation right, your therapeutic rapport that you'll build with the client, your ability to earn trust and actually be more of a protective aspect in their life will increase, exponentially. Now I want you to look at the circle that's green with the kind of quarter moon yellow. This constitutes those individuals who attempted suicide. And what you see there is that yellow sliver is what is not encompassed in the blue-green area where there were plans. This 0.2 million, or 2% of those with ideation, they made an attempt, but they didn't make any plan. This is the population that scares me the most, to be honest, because this is entirely impulsivity, usually helped out with some substance, intoxication of some type. When this happens, unfortunately, we don't have any great information on, what could have been recognized or done to kind of identify this and respond to it in a timely way. And that, of course, is going to give all of us pause, because we see suicide as a volitional act, and so we perceive that it can always be prevented. And like I said at our onset, I don't know that that is a realistic, scenario. I think that we can obviously reduce the vast majority, but not entirely. So that 2%, we don't have a ton of great data here, but we do know that in most of these cases, we had somebody who was clinically intoxicated, whatever the substance was, and it's overwhelmingly alcohol. But like I shared, 1 in 5, it was opiates, usually on top of the alcohol. They tend to be younger. So our brain finishes developing around age 25, 26. So impulsivity levels up until that point are still relatively high, because that part of the brain isn't fully formed yet. So given that, when you're assessing children, adolescents, even young adults, including maybe young parents that are part of the system that you're intervening with, you do have to account for impulsivity. And this is where having safety plans that try to mitigate as much of the risk as possible become even more important, right? So somebody in their 40s, who has a concrete suicide plan, most of the evidence suggests that if we limit their ability to carry out like that plan by limiting their access to the means, they're going to be okay. Give you kind of a humorous example, not that there's humor in somebody suffering, but this particular case was somewhat humorous in what the plan was. I was working in Arizona at the time, and doing this mobile crisis response job, and saw this particular individual probably 2, maybe 3 times a month. And his plan was always the same. He was going to blow himself up with a bazooka. Okay. And since it was Arizona, I did always make sure I asked, like, oh, so have you had a chance to get a bazooka yet? Because you never know. But he never had, and never once did I hospitalize him. He was committed to that plan. And when I had first assessed him, he said, the only sure way I can think of that I couldn't survive it would be to completely blow myself up with a bazooka. Now, I don't know why he arrived at this belief, but that was the belief, and I left that intact. Shooting himself wouldn't work. He wasn't worried about that. He didn't think cutting in his wrist or something was going to work. He didn't want to take medications in case it made him sick. He didn't want to suffer. That was his plan. And so as long as he didn't have a bazooka, we were able to clinically rate him as being, a low risk, and told we'd see him, in a couple more weeks when they called again. But again, we benefited from him being older. Somebody younger, it's not as clean. So what I like to see in terms of making plans, and I want to use the term, safety plan, and differentiate it from what many of us have been exposed to that we would better describe as a safety contract or like a prevention contract. Contracting for safety, no evidence to support that it works, right? In fact, getting somebody to pinky swear that they're not going to like kill themselves really is, it just doesn't make sense, right? Because the truth is that most people, if they're really in that desperate crisis state, will say or do anything to relieve their pain and their suffering. Which is why one consideration we always want to have is that we talk about suicide and homicide as though they're these completely different constructs. But from a safety standpoint, keep in mind that people who are suicidal very often can be homicidal, while maybe not in intent, but in action. As an illustration of this, one of the most common plans I hear in the ER is an individual say that they're going to drive themselves into oncoming traffic. And when I ask, what about the people in the car you hit? What about them getting injured or killed? Every time, the same response, this moment of shock. And then they look at me and they're like, never even thought about that. Which gives us a lot of insight into the desperation of the moment, that they become in that moment very hyper-focused on themselves. They can't see past their own pain. These are not individuals who are insensitive to others or lack compassion or sympathy or care. In fact, they're shocked that they never thought about the ramifications. They were truly blinded by their own pain and discomfort. And it's important to recognize that too often people have been hurt unintentionally by an individual who was trying to carry out a plan to kill themselves. So worker safety perspective, just be mindful of that, recognize that that does present some potential, danger that you want to account for. But, those who are making attempts without any plans, anything we can do to protect them from their own impulsivity. And what I would also lump in here is if we're working with somebody who has a known substance use issue, we need to account for that if there's any suicidal planning and really do our level best to make a plan, not a contract, but a plan that's going to reduce their risk. So plans should feature things like eliminating sources of danger. We talked about that, medicines, firearms. It should involve who are they going to call first, second, third, fourth, fifth. You want to have backups for your backups. I don't demonstrate this because I don't want to tie up a resource, but as the suicide rate has increased, so have calls to the National Suicide Hotline. I hear all the time people who tell me that they try calling the suicide hotline and the phone just rang and rang and rang and rang. And they are over-resourced. Now, local crisis support numbers, not the same concern, but the National Suicide Hotline, that is something that's been pointed out for several years now by quite a few people. And I've seen cases where somebody's like, well, if you're thinking of suicide, call this number, the suicide hotline. It's like, not enough, right? We wanna create a plan that is easy for the individual to follow and allows them to not have access to things that would easily allow them to do something impulsively, as well as ways to prevent it from even getting to that point. People they can talk to, things they can do. Right. So let's go ahead and take another 5-minute break there. Our discussion here. And I wanted to go a little bit deeper into some of what we've been talking about in terms of the trends and statistics, and do this because it's so helpful when we're doing that actual assessment, right? So first thing I want to talk about is what we see in terms of the difference in suicide between males and females. The rate for men not only has always been higher, but look at this, window, 2010 through 2019. Among females, the rate didn't rise very much, but for males, it was a substantial increase. So it's important to recognize that not only are males more at risk in terms of for completion, but for any number of reasons, they've experienced, relatively speaking, a greater increase in risk than even, females had during this period of time. And I think this is helpful because we're still, of all the mental health inequalities we have, and of all the stigma that exists out there, the fact is that many men cannot get past a form of toxic masculinity that makes asking for help of any kind a reasonable option. The good news is that this definitely has a generational difference, and we're not seeing it as much in younger people. So that's good news. But what's interesting, especially when I'm working with police, firefighters, trying to get them to open up about how they're feeling. It's like getting cats to march in a parade. And, I'll ask them, I'll say, so if we're playing basketball together and I bump into you and get my sweat onto you, is that going to be a problem? Not going to bother you? No. How about if we're out on the job and I get hurt and I bleed and my blood gets on you? Is that going to be a problem? No, of course not. What if I'm really hurting and I cry, I got my tears on you? Well, you need to figure that stuff out. You know what? Like that's you. It derails everything. It just falls apart. And unfortunately, I don't know of any great solutions to those biases, but we know that it's far more complicated than just gender norms. We've been looking a lot in recent years at the fact that adult men don't do a great job of having a lot of friendships. And part of it is that, we know there are changes in relational dynamics. Like if you couple up and have children, you tend to build new relationships with parents of similar age children, and that becomes kind of the focus. Or, couples make friends and maybe, one partner and the other partner get along, and then the others are kind of along for the ride. There's a lot of reasons why adult relationships are a little bit trickier to navigate in general, but the likelihood that adult men will have, good friendships is very, very low. And so we've identified this. We knew it anecdotally. We've confirmed it with a number of different population-based research efforts. And now the question is, well, how do you teach men to have friends, right? And what always cracks me up is the number of times that having lived in different areas, I kind of had to start over building friends many times, and I'll be doing something, maybe volunteering at some place or whatever, and I'll be chatting to a guy there. I'm like, hey, do you want to grab a beer sometimes? And their first look is always like, are you asking me out on a date? And I'm like, that wasn't my intention, but you need to figure out what's going on with you. If the first thing you hear when another guy's like, hey, you want to grab a beer, is like, oh, you sexually want me. Oh my gosh, I knew women couldn't withstand me, but apparently now I'm just, oh, nobody can get enough of me. I mean, it's ridiculous. I don't, men are a disaster. And I include myself in that. I'm better trained now. My wife has aged significantly from helping with that process, but like, we're a disaster. Again, I have a lot of more hope though, that a lot of these stigmas and barriers, social barriers around mental health and healthier well-being in general are not shared by most millennials, and certainly like it's rare. Like, do you find it in you know, in Gen Y, Z? In fact, my wife often talks about how it's almost becoming trendy and cool if you're an adolescent female to have a therapist. And I'm like, well, there's that's kind of happening. But again, we don't know what to do. And the friendship issue is really important, because when we think about how we actually intervene in most suicides, it takes somebody recognizing somebody is not okay, is not doing well. And if men don't have close friendships, who's going to notice it? Especially if they don't have a romantic partner. But keep in mind that family is the last that can actually ever really notice what they need to notice. It is very difficult for family to see problems within the people they love, because we don't want to see them. That's why it's unethical to treat family members. We can't be anywhere near objective or see things as they really are. Now, what I also think is interesting is that when we talk about suicide and how it's, again, we used to use the word epidemic for everything, and then, you know, COVID, and now we're like, okay, let's be cautious in how we use this word. But the increase in suicide has not been a universal phenomenon. Now, when we look at the role that race ethnicity plays, the consistent finding, I'm presenting 10 years here, but we could go back 50 and see the same thing. American Indian, Alaskan Natives, far and away the highest rates relative to you know, the race ethnicity of anybody. They have the greatest risk. And if any of you have ever been on a reservation, not a casino part of a reservation, but on the actual reservation, they're some of the like most hopeless feeling places. They tend to be in incredibly remote areas. When I worked in Arizona, that mobile crisis job I had, my company had a contract with the Gila River reservation and a couple of other reservations. And one of the reservations was literally halfway between Phoenix and Tucson. And if any of you have ever driven from Phoenix to Tucson, you know what's out there. Nothing. In fact, here's how utterly remote and devoid of use that land is. There's an airplane graveyard. Literally, where do you throw away old airplanes, like jumbo jets? There, they have the place because you can't use that land for anything else. There's also an Army test site where they certify Apache helicopters who fired depleted uranium rounds. They certify them there because nothing could ever grow there, so it doesn't matter if you irradiate the soil. But then there's also this reservation. So it's so far away from resources, from anything. It's 45 minutes from the Bureau of Indian Affairs in Phoenix. It is remote. Streets aren't labeled. It has a feeling of like desperation and the sense of like, oh my gosh, we did this and had decided not to fix it apparently. And like, I don't know how you fix it, but it's hard. There aren't resources. There's a well-earned mistrust of outsiders. It is a difficult population. And it's also obviously a population that child welfare system has had a very difficult relationship with over the course of its history, right? So it's something we acknowledge of like, yep, it's bad. It's really, really bad. Now, the next line, which is dark green, is the white, represents the white population. Most of the time when we're doing health studies, we use, and we're looking at the role of race ethnicity, we use whites as the comparison group because we expect that they're going to have higher socioeconomic status, and that will translate into better health outcomes. But there are a few areas where that absolutely does not hold true. One of them is around infant and maternal mortality. Does not hold true there. The other area, suicide. And what frustrates me, and something I've talked about with many colleagues and brought up at more than a couple of conferences, is that we approach looking at this, looking at the issue of race ethnicity, using a pretty gnarly set of blinders, because when we recognize this doesn't match, we're like, oh, that's weird, that's strange, but we don't go any further with it. Because as we go down, that yellow line just represents the overall average. But look at the three lines that kind of almost overlap each other and do overlap each other in many different points along this continuum. Asian Pacific Islander, Hispanic, Black, African American. Not only is it lower, but it is lower by an order of magnitude. We're not asking the important question of what do we have to learn that would help us reduce suicide in other populations? What are the inherent strengths? As opposed to always talking about barriers and limits and weaknesses, we don't do a good job of saying, what are some of the strengths there that might be something we could look at more? So my own research has looked at the role that religiosity can play as a protective effect, and that may very well be part of what's going on with especially the Hispanic and Black subpopulations. What's interesting is that the risk for suicide for the Asian Pacific Islander population is also very low. And suicide is often not discouraged. Depending on the specific culture, often it's seen as a remedy even in cases of dishonor. So even when suicide is not explicitly forbidden, there's still a lower level of risk. And I would love to hear some of your ideas on what might be at work here. Feel free to throw it in the chat or unmute yourself. Why do you think that some of the non-white groups that historically we always look at as having worse outcomes, why do they seem to have much more protection, at least in regard to suicide, than we see with the white population? Okay, yeah, Kelly, religious cultural beliefs. I think that's huge. Family and social supports. Yeah, Kimberly, I think that is so critical as well. A study that came out quite a while ago now that initially I was like, that was a weird thing to research, but have since really come to see the deep value in. A study found that extroverts seem to be at less risk for suicide than introverts. And on the surface, it can almost appear like, oh, they're more outgoing, so they're happier, and so they do better. And our common misbelief that introvert equals shy or antisocial. Introversion refers to the way that we take in energy as like being alone to recharge, versus extroversion, where you recharge your energy by being around others. And why extroversion versus introversion is so significant is that when an extrovert starts not doing well and starts kind of isolating, because they're extroverts and we're recharging, we're around a lot of people, people start to notice very quickly, I wonder where so-and-so is. Hey, why aren't they out tonight? Because introverts need to be alone to re-energize. They don't get noticed as being out of the group quite as quickly. And as a result, often things progress, especially when we're talking about worsening depression, progresses without anybody recognizing or knowing. One of the biggest things that cultural beliefs often provide are the primacy of the family, right? And especially extended family. So when you have an extended family that doesn't just contain blood relatives, but involves others who are like that. I mean, even growing up in rural northern Michigan, there was this older woman who lived across the street who was a grandma, but she had no blood relation, but she was another set of eyes to be monitoring, to be watching, to be checking. And the sense that there are more people that you can go to when you have a problem, and actually having more people you can go to definitely has a protective benefit. Plus, when we're in isolation as humans, we tend to not do great. And here again, for those of us who are more introverted, it's easy to have people not understand what our being by ourselves means. And so it's, again, having more people that can check on you, even if it's not because you normally are around, really beneficial. And absolutely, Kelly, that's an important point. Religious beliefs that deter. Yeah, it's absolutely true that if somebody believes that dying will not end their problems, but maybe just begin them, that is definitely a protective benefit. And here's something that often shocks people when I'm talking about this topic. I have on more than one occasion when somebody's acknowledged that they're Catholic and that's important to them, and I'm seeing them because they're suicidal. I've asked, so what is the church's position again on suicide? It's a mortal sin, which is the most serious you could commit. And I'm like, so do you think about that in context of suicide? And they're usually like, that's right, I can't risk that, and this isn't that bad. And I've had people say, oh, is that an okay to use somebody's religion to kind of throw it in their face like that? And what I remind those people is we're not having a theoretical conversation here. And what I tell all my students is this: when people talk about life or death situations, this is one of them. And the rules need to be not beholden to some noble idea, but beholden to a value. If we value first, do no harm, if we value preserving life, then what we do to do that is really the evaluator. Do I think it's appropriate to use somebody's religion haphazardly and use it as a form of coercion or manipulation? By no means. Do I think asking about it and seeing can it be a source of help, or if it can be a protective tool, asking for that? Not only do I think it's important to do, but I think it can yield valuable insights, right? Because there are many additional safety mechanisms that could be initiated through that, whether it's a protective belief because they're afraid of going to hell if they commit suicide, or if it's that there are more options through their church, synagogue, temple to actually form social connections and get help, often get mental help when they might otherwise not be able to. We want to take advantage of every resource and not see it as a taboo, controversial kind of thing. Oh, and by the way, something I should point out, the possibility always exists that I'm completely wrong about everything. And I only point that out because I never want to not take seriously that, when I'm standing in front of a classroom or presenting on a topic like this, I speak with an expertise, and that I've met plenty of experts who were wrong, and I know I get things wrong a lot, and so I always try to point that out. I could be completely wrong about a lot of this. I'm presenting you what I know from best practices, from the research as it exists, and from my own practice. But you'll also see that at the bottom of every slide, I've got plenty of citations for you to go and look at things for yourself, and encourage you to always do that, right? And I do that because one of the things we're going to look at is that I can be right if it was 1999, or I can be right if it was 2017, but not right in 2022. One of the most concerning things that we're going to see is that things change over time. And this is why I think it's important to stay current, as practitioners in our field, and also stay current in the things that are routine parts of our job. Again, my subtle plug for, we need to have, if we're going to have CU requirements for everything, then, suicide training would be probably a pretty important one to have. So, end of that sideways plug again. But speaking of some of the trends and concerns we need to talk about, when we look at the question of race, ethnicity, and actually break it down, looking at the actual behaviors. So considering attempting suicide, making a plan, suicide attempt that's so severe it requires treatment, attempting suicide. Part of what we see in general is that the overall trends hold true in terms of the risk factors. But do note that when we look at suicide attempt requiring treatment, we start to see some things look a little bit differently. Also pay attention to the fact that the difference between plan and attempt can really vary. So for that first, not the overall column, but the AIAN, American Indian Alaskan Native column, the difference between making a plan and seriously attempting suicide is very small, right? But for most of the other groups, there's a bit more room, anywhere from 2 to 4% difference. But adolescents in general, if they make a plan, attempts seem to be a bit more likely than if they're older. So again, just to highlight the reality that that impulsivity is still a critical piece we have to factor in. When we look at, from a perspective of like, how does race and gender kind of come together? We see that it varies again. While overall there's still a pretty big gap, in terms of like women and men, we know that this actually varies by race and ethnicity. And in this graph, we can see how has this changed over time. And what we notice is that the risk has increased disproportionate by race. And it's something that we probably, need to explore a lot more. So again, I want to draw your attention to the second column. This is white females. The blue bar, 4.7, represents the rate, 1999. The green bar, 7.9, that represents 2017. So their change during that window of time was quite pronounced. But now jump 2 columns over to Asian Pacific Islander, API. Marginal chase, in fact, barely statistically significant. Similarly, a small increase for the Hispanic population. A more substantial increase among Black women, and a monumental increase in American Indian Alaskan Natives. So what does this mean for what we do? It means that we can't not factor in some of these, the consideration of why this might be. And am I saying that we're going to recalibrate some of these, risk based solely on their race or gender? I'm going to say no, but we are going to need to think through how much of basically the social conditions that make this true, how much of that can we ever assess, identify, evaluate? And so again, we don't want to use statistical realities as a predictive route in an assessment, but we don't want to ignore that clearly there are more risk factors, more things going on here, and it deserves some attention. With males, there's a less pronounced increase. We do see some bigger jumps with some of the populations, but we see more populations that, despite the overall increase in suicide, there wasn't a ton of change. So part of what this actually does suggest is that the driving force behind that big increase in over suicides was not universally experienced. There was more increase in women and more increase in certain racial ethnic subpopulations. So that's an important consideration. Now we're getting to some of my favorite examples of how to understand how many of these factors come together. This map looks at or portrays suicide rates at the county level between 2013 and 2019. And the darker the blue number, or the darker the blue color, the higher the rate of suicide, meaning more people per capita completed suicide in those areas. What do you notice about the trends of where it's the darkest blue? A low population. You got it. So when we look at, this, Brittany, that's also a good point about the risk of seasonal depression. Before my wife moved here, she had been living for a few years in Seattle. And she talks about how she doesn't love the cold of Michigan. She lived most of her life in Arizona. But the fact that we have a good amount of sunshine, even when it's cold out, was way better to deal with than when she lived in Seattle, where you didn't see the sun from October through May. And that definitely has a pretty major impact. And so there's definitely something to be argued that many of the darker blue areas do have some seasonal components. Our best understanding right now is that it directly affects vitamin D levels, and that's what leads to greater depression and therefore potentially higher suicide rates. Also, areas that are more extreme in terms of temperature, people are more likely to isolate. So when you look at like Arizona, they have sunshine, but Arizona in the summer is not inhabitable unless you're in air conditioning. And so people don't go out and play. You literally see kids riding their bike outside for 20 minutes from like 11 to 11:20 at night because it's now finally under 100 degrees. I miss living in Arizona this time of year, but the day I moved back to Michigan, it was in July, the heat index was 154. Like, it is not hot. It is literally an oven, and people isolate. They don't go out. They don't do as many things because it's too hot. So there's definitely a component like that. When we look at, Michigan, northern Minnesota and that, yeah, there's snow on the ground in July in some of these areas. Like you are not only geographically isolated, but your behaviors change. We see humans engage in hibernating like activities. But the rural thing seems to be one of the biggest predictors. And if we kind of zoom into Michigan, you can see the more rural the county, the higher the rate of suicide. Now, for those of you who know anything about the northern part of the Lower Peninsula, it's pretty isolated. I grew up in a county called Missaukee County, which is about 45 minutes southeast of Traverse City, which is a place I'm sure more of you know than Missaukee County, or my little hometown of Lake City. If I had wanted to see a therapist in high school, which, dear Lord, I should have seen a therapist in high school. So I waited till a judge helpfully suggested I talk to a therapist. That's a story for another time. We'll have that conversation another day. But anyway, if I had wanted to see a therapist, the closest one was in a town called Cadillac, and that was a 20-minute drive. And there was exactly one. I would have had to go into Traverse City to have had more than one option. And I do some consulting right now with the Center for Behavioral Health and Justice at Wayne State. And they're working with some of the northern counties on some jail diversion related to mental health efforts. And so I work with a lot of these counties. They have to respond to mental health needs, oftentimes 2 or 3 counties away, where it would be a 2-hour drive through rural areas and dry roads, mind you, to go check on somebody and then come back. So you might only be able to see one client in an 8-hour day. There's such a lack of resources overall, but when we get to rural areas, it's extreme. And, you know, rural areas, people don't want to go there and live, especially if they've left and gotten educated. There are jobs open everywhere, but I've had people in Grand Traverse County, Antrim County, Kalkaska County say, we're offering $65,000 a year for some positions. And you can live like a fat rat up in that area. At $65,000, you're a millionaire, like up there. Like you can buy 50 acres for what you could barely get a house for down here. Like, I mean, you just like that money goes so much farther up there and it's still not enough because of the isolation. So access to resources in terms of treatment are just super low. And what's interesting too is if we look at suicide rates on a global level, we see some interesting things where countries with higher rural populations definitely have higher rates. So we see some similar trends. We see some trends where there are attitudes towards, you know, mental health that aren't very positive, translating in that. But what I also like to highlight when I share this map is that if I had shown you the same World Health Organization map of suicide rates from 2012, half the countries would have been white because they weren't providing data. So there's actually some good news that more and more countries are actually prioritizing this, and this is becoming a bigger issue. I also highlight this because the reality is we're a global village now, and we have been for quite some time. And especially in Southeast Michigan, we have a very large refugee population, and we've got individuals that come from a lot of different areas that live here. And it's one of my favorite things about this area is that type of diversity. And it's important to recognize that we don't know as much about some of the risks associated with, you know, certain cultural identities that we might have contact with. And so that's definitely a limitation that we experience. We know that age has historically been a great predictor, but it hasn't always been as consistent of a predictor as we would like. Historically, if we go back really to the early 2000s, suicide was far more prevalent in the 65 and over population than was in any other group. But we started to see this dynamic change pretty quickly in, you know, the 2005, 6, 7. And when we get to 2010, I want to draw your attention to how that 25 to 44 and 65 literally were trading places throughout time, that not only had there been such an increase in the 25 to 44-year-old to get there, but now it was competing, and 45 to 64-year-olds had taken over. Also note the bottom line. What was going on in 2013 that saw this steady increase and then the spikes that we see in 2016, 2017? Seems like a lot of that was the effects of the recession catching up. You know, your family loses the primary income earner, you end up not being able to maintain your house, you relocate, your social circumstances are different, you feel like your options for the future are different. Like a lot of things start to kind of collapse upon themselves. And, you know, it was interesting that in the early debates around what do we do in the face of a pandemic, and, you know, are there ramifications of economic shutdowns that could affect mental health? I did feel like people were a little too quick to dismiss that reality because the truth is we can look at most major economic dips over the course of US history and see a few years later a correlation in worsening mental health and even suicide rates. So there's definitely something there, although the effect is not direct. And certainly that conversation had many more considerations than purely the question of mental health or wellness. But it's important that we as professionals recognize that there's something to it, but it may not operate in the same way for everybody. Because as you can see, while everybody did experience an increase, that increase definitely varied by age. So that's worth paying attention to. And this kind of gives you that perspective. You can see it a little bit more clearly. And go back to 2000, that yellow line is the 65 and older, and they were on top. But now they've literally been eclipsed by 45 to 64-year-olds. Just for the sake of time, I'm not going to spend too much time on this, but I wanted to just show you this graph because it shows what happens as we enter different stages of development in terms of aging to the relationship between thoughts, plans, and attempts. And what you can see is that everything decreases. And this probably highlights something that we need to pay attention to when we're thinking about planning for safety and intervening. If we can help change the narrative of what there is to look forward to, what hope there is, if we can create things to look forward to, and I mean a week out, 2 weeks out. A lot of times when people talk about assessing somebody's future orientation, that is, are they thinking about the future? They look at things like 2 years out, 4 years out. I like to, especially with adolescents and children, start with like, do you have any plans, anything you're looking forward to this summer? And then start pulling it back, because if I'm getting no, 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 I'll even ask like, hey, later tonight, anything you're planning on doing, anything you're thinking about? No, I haven't thought that far. That's telling me something. This is somebody who has stopped having any type of future orientation. This is definitely somebody who's at too great of a risk to not intervene with. The more they have a future orientation, the more they have to both nurture a sense of hope that things will get better, and the more they like clearly are not stuck in this belief that things can't get better because they're looking forward. So similarly, when you're assessing a child or an adolescent who will say something like, yeah, I want to kill myself, my parents took away my phone, and I hate them, and I want to die. Which, pretty strong relationship between taking away somebody's phone and them wanting to die when they're children or adolescents. I see a lot of that in the ER. And I used to get frustrated by it and think like, listen, kid, if this kicked your butt, I don't know what to tell you, because life's gonna get way worse than this. But then part of what I started to realize was what it meant to have your phone taken away, right? It was a lack of access to your friends and interacting with them. There's a lack of keeping up with understanding what was going on. It was a lack of a way to interact with much of the world that you're used to. Many of their coping strategies involved like zoning out and playing a game on their phone. Like it actually was a big consequence. And subsequently, I've actually kind of changed my tack and talked to parents that, you know, you should see taking away a phone as a far more restrictive and impacting consequence than maybe it would have been when we were kids. Because if you'd taken my phone away from me when I was in high school, you would have had to cut the freaking cord and rip it off the wall. Okay, like unfortunately, this is something that happens to us as we get old that we don't like to admit happens, but we don't think about things in the current context. So parents like, well, I was grounded from phone privileges and that was an appropriate consequence. That's not the same thing as taking away, you know, somebody's phone when they're 15, 16, 17. It's just, it's not. And we can talk about why maybe it shouldn't be that way. Like, and I'm in favor. If you want to form a petition, I'll sign it, get rid of cell phones and email. That would be wonderful. I'd do that in a heartbeat. But if we're going to keep them, we should recognize that we have created a sense of dependence on it, especially for younger people. So you do have that individual who they want to, you know, kill themselves because this was taken away, but they also talk about looking forward to something coming up. often in those situations, all you have to do is talk more about that and be like, you know what, this is bad. And I can even talk to your parents about making sure we pick appropriate consequences. You did something wrong, you screwed up, there's a consequence for that, but we can talk about that. But I want you to stay focused on, you know, how much this isn't going to matter as soon as you get to the water park in May or whatever they're looking forward to, redirecting them to that future orientation. And again, it's not as inconsistent for children and adolescents to be future oriented and to verbalize a desire to want to die. As we get older as adults, that's not the case. Adults who are starting to have suicidal thoughts, they're not thinking much further ahead of themselves, like mostly because they can't. They're at the limit of what they can cope with. And in terms of looking specifically at high school students, we can see there's still that gender effect that we talked about. And what's interesting here is that males actually exhibit fewer suicidal behaviors across the board, even though they do complete more often. So again, it makes it hard to apply any like concrete, oh, if they make a plan, they're at more of a risk. Well, more females make plans, but less attempt, you know, still and require treatment. And in terms of completion, none of this tracks very clearly. It makes it definitely challenging, which is why part of what really makes the biggest difference in terms of doing a quality assessment and in being able to actually come up with viable solutions and interventions really relies on the relationship that you've cultivated. And this is hard because depending on your role within child welfare, do you know, how much contact do you have directly with, you know, the child or adolescent? How much, you know, time can you devote there when you've got the case load that you do? Like, these are real challenges, but what's important to recognize is there's a return on your investment. And if you need a way to maybe kind of triage, like, where am I going to spend more of my time? The individual in adolescent years, even late childhood years, with suicidal thoughts, they're a good place, because it's literally just the dynamic, the power of, you're this consistent person in my life, that seems to be one of the most remarkable factors in their resilience when they're facing suicidal thoughts and ideas. I want to jump ahead a little bit to look at adolescent depression and its relationship to suicide risk, because when we talk about adults, like I mentioned before, depression is the diagnosis most closely related to actual suicide. And I know we're running out of time, so I will be brief here. But depression has actually been relatively stable during the period where we've seen the biggest increases in adolescent suicidal behavior, which tells us a few things. One, it tells us that depression is not as much of the story for adolescents as it might be for adults. The second thing it tells us is that, you know, we might need to be screening for more than just depression when we're looking at somebody's suicide risk when they're in adolescence. Now, you really want to see some information that kind of makes you scratch your head and feel like, huh, what do we even do? This graph displays the percent of adolescents who endorsed having considered suicide in the past 12 months. And I go all the way back to 1991 because I wanted to highlight that it was really, really high. Almost 1 in 3 adolescents in 1991 endorsed having had serious suicidal thoughts in the past year. Now look at what happened over time. It dropped to a low in 2009, and then it rose slightly to where we are in 2019, the last year, with solid, reliable data. And it's still 10 percentage points lower than it was in 91, but the suicide rate is so much higher. there's an impulse factor at work now. And I'm sharing this in part because we don't know how to explain this. And also to caution you away from over-reliance on some of the more traditional models of assessment, right? Instead, we want to really get to the idea of what are the risks that we can modify, right? They're going through this unstable housing situation. How can we, use our, at times, very significant powers, especially if you're doing casework, to try to reduce some of that. One of the things I've never understood that we do to children, parents figure out that they can't live with each other, so they get separate places. And then because it'd be too much of a hassle, they expect the kids to just move back and forth, depending on whatever the custody schedule is. When children desperately need stability and would benefit much more from having a place and letting the parents rotate in and out of it. And when you present this idea, then most parents are like, that would never work for me. And it's like, yeah, but just so you know, it would be much better for your kids. And so you're choosing your comfort over their well-being. So just throwing that out there. But it's worth considering that if you're looking at situations where there's a lot of instability, and this is somebody that's you've identified as having some suicidal risk behavior, that's a modifiable risk. How can you create a bit more stability in their life? How can you reduce contact to certain distressing events? And we know that this is often one of our biggest frustrations in what we do. Sometimes the court orders something that gives contact or interaction with people that we strongly feel should not have that contact. I think it's important that we never lose sight of our role as advocates and really push back on the court harder, especially when we know that there are some of these suicide risk factors at play. But many of the risks that you're going to encounter with children involved in the child welfare system, many of them are not modifiable based primarily on the fact that they're not adults, right? There's a lot that we just simply cannot do. So instead, we focus on protective factors. Well, what things reduce the likelihood of suicide? Well, we've mentioned a lot of them, right? Like, religious beliefs that deter are a great source. But interacting with healthy adults is one of the biggest ones. So we need to do a better job of recommending things like Big Brother, Big Sister programs. We need to see our contact with them as not being, just a procedural responsibility of our job, but as an opportunity to let them know that there are other adults out there that are safe, that they can approach, that they can talk to. And oftentimes it literally is just your presence in a consistent way that communicates that. And so much of the good you do in ways that you don't even recognize you're doing. And it's phenomenal because, again, most of the kids that we come in contact with that have these risk factors are going to make it. They are going to survive. They are going to succeed. When you do identify those that have the suicidal risks, when do you worry? They're adolescents and they've made a plan. That's when to worry. That's when we need to get them some help. That's a great time to go to the ER. When they are using suicide as a way to cope with the distress going on around them. But if we're talking about somebody who's just having the thoughts, that's not something we have to escalate so far. That's something we can support, certainly with outpatient experiences, but this is also where just the power of the relationship really comes into play. I know I'm a few minutes over time, and I want to free you to get on with your days. I got some time though, so I'm happy to hang back and answer questions. There's a lot more and some technical stuff that are in these slides that I think will be available on Wayne State's website. So you can download that and get some more of the specific procedural stuff so that you have that. And thank you for your time and the opportunity to spend a little of our afternoon together. Again, I'll be happy to hang out here and answer questions if you have them. Have a good day.